Thank you so much. And today our session is the second part of communication. And welcome to all the delegates back to the second session. So good to see all of you. I'm going to share the screen. Okay. So as I said, today is part two. Today we are going to talk about some advanced communication, uh, as I call them, procedures. So today we'll be covering communicating bad news. We'll talk a little bit about the various models and also why bad news should be communicated at all, the rationale for it. From there, we will divert our attention to another topic, which is collusion. What is collusion and how do we go about managing it? And once we touch upon that, we will come back to our original topic, that is communicating bad news. This time, we will try to understand how it is done. And last, we will also touch upon how to deal with an angry situation which we have to face fairly often in our practice. So, important thing about breaking bad news is it is not easy because telling truth is hard, and over the ages it has been known that those who speak the truth sometimes they find little difficult to deal with news which are bad in nature. In many parts of the world, especially in the Asian culture, definitely true in our culture, we do not tell the bad news to the patient. Even if the patient has come with the family, we tell the patient to go out of the room and then tell the bad news to the family. So we do not disclose to the patient, and this model is called non-disclosure model. And we have our reasons for not telling the patient. Some of the reasons are there in this dialog box. I do not tell bad news to my patient. Let them enjoy their life while they can. Besides, I'm such a kind hearted doctor. So many a times we think we are doing the right thing by not telling the patient. But what about the patient who wants to know? The patient may want to know for various reasons. And because of this, there can be a conflict between the medical professional and the patient. And please remember, the first and foremost principle of medical ethics is patient's autonomy. And what that means is the patient has the right to know. So when we practice a non-disclosure model, this gets into conflict with the patient's right to know. But in our culture, the patient's autonomy is not as sacred as the family's right over the patient. So in our culture, it is the family which brings the patient to us and not just the patient coming to us alone. In many cultures, especially in the developed countries, they practice full disclosure mode. That is, they tell everything to the patient. because there you cannot tell the family without the permission of the patient, because in those cultures patient autonomy is taken very, very seriously. The patient can sue you, take you to court if you reveal the diagnosis to the family without telling the patient. But this full disclosure model can also get into conflict with a patient who does not want to know. Because just like the patient has the right to know, patient also has the right not to know. So if we practice full disclosure model, we can get into conflict with the patient who does not want to. So what do we do? That means the non-disclosure model and the full disclosure model both have its problems. Therefore, we have to figure out something that suits the individual sitting in front of you. That person, each person is different. Each person is an individual. So, what the individual wants, we have to design a model, and therefore we call them an individualized disclosure model. Basically, we have to we have to find out whether the person sitting in front of us wants to know or not. If the person doesn't want to know, we do not tell. If the person wants to know, then we tell. And we also need to figure out how much the person wants to know. So, depending on how much the person wants to know, we give the information. Not less, not more, just the right quantity that the person wants. So, this is individualized disclosure model. Now we have to figure out how we are going to do this. But that is for later, not now. Right now, we will talk about why it is important to communicate bad news. I'm going to put in front of you three primary reasons why it is important to communicate bad news. One, it gives an individual a chance to finish things that he or she wants to do before they die, or before they become so debilitated physically and mentally that they cannot do those things. So before they become debilitated or die, there are a lot of things that a person needs to finish. For example, they may want to get their finances in order. Simple thing like telling the password of your account to your spouse, because all through the life the spouse may have given the the other person, the patient, that you take care of the finances. But now it is time for the healthy spouse to figure out all these things. So instructions can be given. And what about the future of children? What needs to be done? So all of these things. And what are the things that I wanted to do but never got time to do? The bucket list. Making memories, going to places where one wanted to, going and meeting people, and enjoying life before life gets old. It is time to improve relationships, time to say I love you. It is also time to improve your soul's burden by giving forgiveness and asking forgiveness if there is anything that needs to be forgiven or asked to be forgiven about. So, a lot of things there are to be done. Now, less than 10%, around 7 to 8% of the population dies suddenly. They never get a chance. It may be an accident or a severe MI or any something like that. But majority of the people get a chance to finish the things that is important to them. But they will think about it only if somebody tells them that their life, the days are numbered in weeks or days or months. Only then somebody will start thinking along those lines. So if you don't tell people the bad news, they will never reach this point of thinking, I need to finish a lot of things before I die. So we are denying them that important closure in their life to finish the life's business. The second important point is if the patient does not know the reality, from the patient's point of view, the patient's expectations are normal. I came to the hospital to get better. From our point of view, we will see it as unrealistic expectation because we understand what is the reality, or maybe the family also understands what's the reality, but nobody told the patient the reality. So from the patient's point of view, what is normal expectation, from our point of view it is unrealistic expectation, but the patient doesn't know that. And because we cannot ever reach what the patient wants, the patient gets irritated, frustrated, and loses faith in our abilities. And initially, the patient may say, oh, very good doctors, very good nurses, great hospital. But after some time, the patient will say, oh, they don't know anything. They can't treat me. I'm not getting better. These people are only after my money. So these kind of situations comes up, and then the patient may demand, take me to some other place, and the family cannot refuse. So the family takes the patient to another place. On the way to the new place, the patient's hope rises. Patient is happy, I'm going to a better place. But after some time, the same situation in the new place. So then the patient again blames the medical professional there, blames the medical institution there, goes to the third place and the fourth place and the fifth place. Eventually, the patient starts blaming the family members, saying, you people don't want me to get better. That is why you are not taking me to the right kind of place. And this goes on and on. And so much of time, energy, money, resources, everything is wasted just because we did not tell the truth to the patient. And remember, if you're staying out of your house, you have to pay even for a bottle of water. And because the family member has to accompany the patient, they cannot earn an income. So there is only expenditure, no income. And naturally, they will have to sell, take loan, and then have to sell everything, including their house, so that they are literally on the road. Eventually, the patient dies. So, what was the point of going around looking for treatment which did not exist? Spending so much of time and energy and pushing the family to poverty just because we did not make an effort to tell the truth. Therefore, to prevent hospital hopping and doctor shopping and associated torture, suffering, we must consider telling the truth, telling the bad news. The third point is barrier in relationship, because the patient does not know, the family has to behave as if everything is normal. as if everything is fine. They have to put on a mask and act as if in a drama that everything is fine. When the family gets overwhelmed, they go to the farthest room and cry there, wash their face, and then again come and behave as if everything is normal. They sometimes go to their relative's house and cry there. They go to the neighbor's house and cry there. And often they come to the hospital without the patient and cry in front of us because they cannot cry in front of the patient. Only if the patient knew the family member could cry and hug the patient and say how much I love you, how much you mean to me. That opportunity never comes. And when the patient finally dies, you look at the photograph of the patient and wish only if I had some more time with the patient, with my loved one. But what were you doing when the patient was alive? You were playing a drama when every moment was precious. And for this, communicating bad news, telling the truth is important. Look at it from the patient's side. The patient knows he or she is not getting better. The patient's body does not lie to the patient. Everybody else may be lying. The family members, the relatives, friends of the patient, the medical professionals, doctors, nurses, everybody may be lying to the patient, but the patient's body does not lie to the patient. Patient knows, the body tells the patient that things are bad, I am not getting better. But patient also realizes that nobody is telling me the truth. I know something is wrong, but nobody is telling me the truth. I am all alone. Nobody's on my side. Relatives starts coming in to see the patients from far away, and the patients hate them because they come and stand and look at the patient with a lot of sympathy. The patient hates it. He gets angry with the relatives. Why are these people coming into my house? Tell them to go away. But the family has to stand helplessly because they cannot tell the relatives to go away. The patient hears whispering in the corridor and in the next room, and the patient understands they are talking about me, but they will not talk to me. They talk about me, but they will not talk with me. So, a lot of suffering happens, and as a result, the good good relationship, the strengthening of relationship is most important in the last days of our life. And in the last days of our life, we spend the precious moments playing a drama. And this is the real tragedy of the situation. Hence, telling the truth, telling the bad news will prevent the barrier in relationships. So these are the three important points that I want to put in front of you to justify why it is important to communicate bad news. But I underline to those who want to know. We will not impose it on those who do not want to know. And we have to find out who are the people who want to know and who are the people who do not want to know. Now that we have done that, the three important points why it is important to communicate bad news. You may have had experience with family members coming and telling you, hey, please do not tell it to the patient. Only talk to us. Do not tell this to the patient. They will come and plead with us. Please don't tell it to the patient. Please don't tell it to the patient. So this phenomena, this and the family members trying to enter into a conspiracy of silence with the medical professionals. This phenomena is called collusion. The family members will tell the neighbors, please do not tell the patient. They will tell the relatives, please do not tell the patient. They will also tell us, please do not tell the patient. because they do not want the patient to know the truth. So this part, this action, this is conspiracy of silence. They do not want us to reveal the truth, is collusion. Now, why does this happen? Because families simply trying to protect their loved ones from harm. They believe that telling the truth to the patient is going to harm the patient, their loved ones. So it is an act of love. They are trying to protect their loved ones because they love the loved one. They love their patient. They love their family members who is sick. And hence, please remember the family means well. There is no malintention. There is only good intention when family is trying to do this. But it just prevents the patient from knowing the truth. Now, if the family believes that this is going to harm the patient, some people say the moment the patient hears this, the patient will collapse and die. Some people say the moment the patient hears this, the patient will lose the will to live and will stop eating. The patient may commit suicide. So they believe a lot of things. From our point of view, it does not seem very scientific, but for the family, their belief is very, very real. Therefore, do not challenge their beliefs. Do not challenge the reasons why they do not want the patient to know the truth. Instead of that, from our side, the first thing that we should do is to agree to collude. Because remember, we have to focus on the family member at this point of time because the family member is anxious. The family member is afraid. The family member is scared that we may tell the bad news to the patient. Therefore, to reduce the anxiety of the family member, we say, okay, no problem. We will not tell. And sometimes I ask them, what have you told the patient? So they tell the excuse that they have been telling or the lie they have been telling the patient. Some people say we have told it is just an ulcer. Some people say, oh, it is just you're taking medicine for weakness, you will get better. So you can have any number of uh, things that the family member will tell you. This is what we have told. So you can ask them, so is it okay if I also say the same thing? But it is up to you. The main point is agree to pollute. Okay, no problem. I will not tell because you cannot bypass the family and tell the truth to the patient, especially in our culture. Because, as I said, in our culture, the patient is brought to us by the family. So, if we were to do something that the family does not want or something that the family is very, very against, they will take the patient away from us. And then, whatever good that you could have done for the patient, you will have no chance to do it. The second thing is they may get violent and attack you or take you to court. So they can harm you or they can take the patient away so that you can't do any good for the patient. So the first strategy to manage is agree to pollute. Once that is done, the family's anxiety comes down, their fear comes down, and then our job is to earn the trust of the family. For that, actively listen to the family. What are their concerns? What are their fears? What are their beliefs? What is it that they want? Build up a relationship. Sometimes you can build up a relationship in 5 minutes. Sometimes it may take 5 days. But whatever it is, build up a relationship. The more you better you get in the skill of communication, the faster you will be able to earn the family's trust. Family's trust comes from primarily these things. And the last but not the least, make the patient comfortable. If the patient has pain, make sure the pain is taken care of. The patient has breathlessness, do it in such a way that the patient's breathlessness is taken care of. So make the patient physically comfortable and the family will start trusting you very fast. Just think of it in your personal way. Just imagine, God forbid, if somebody who's very close to your heart is suffering from anything, let's say very severe fever or pain or something, and there is one person who treats and within a day the suffering is gone, the your loved one is happy, your loved one is comfortable, wouldn't you trust that person who made this possible? Wouldn't you be grateful? Wouldn't you be thankful? Wouldn't you want to continue to you know have this person on your side? That's what I'm talking about. So earn the family's trust. And once the family starts trusting you, now they will start listening to you. And when they start listening to you, your opinion, your advice, everything is taken very, very seriously by the family. Then you can talk about why it is important to communicate bad news. So you reorient the family point of view regarding communicating bad news only after earning the trust of the family. If the family trusts you, the family will start listening to you, and then you can gradually bring in these topics. As I said, it depends on how fast you are able to earn the trust of the family. It can happen in 5 minutes or 5 days, sometimes never. But it is important to try. That is why the active listening is so important. The skills of active listening that we talked about last time, non-verbal communication, verbal communication, the empathy, showing the concern, and being genuine. All of these things build up relationship and trust. And once you are able to reorient the family, many times the family members ask me, we can't talk this to the patient. Why don't you talk about this, doctor? So in that situation, I tell them, okay, I will talk to the uh, to your son or to your father or to your mother. I also tell them, however, if he or she does not want to know, I will not force this information. I will tell only if the person really wants to know. It is possible that despite your best effort, the family does not agree about letting the patient know the truth. And despite your best effort, if this is the situation, it is possible you may feel frustrated because you made a lot of effort. And if you are frustrated, there is a danger you may push it beyond the point. You may insist with the family that it is very, very important. You must tell. So when you do something like that, it appears as if you have some agenda, as if it is your own personal motive, it is some personal agenda that you want to convey this to the patient. So the family may start feeling like that. So there is a fine balance that you have to achieve, that you make a genuine effort in trying to reorient the family by your counseling communication efforts. But if you realize that despite your best effort, the family is not in favor of letting the patient know the truth, do not push beyond the point. Be prepared for failures. Remember, there is no shame in trying and failing. I repeat, there is no shame in trying and failing. The only shame is in not trying. The only shame is in not trying. And the more you try, you will gradually realize you are becoming a better and more successful communicator. And as your communication skills improve over a period of time, your success rate in converting the family, reorienting the family will also improve. But even if you are the best communicator in the world, you cannot achieve 100% conversion. You will always have failures. So be prepared for failures, but that is okay. So this is what I had in mind about this pollution. Now coming back to communicating bad news, how do you tell the truth? World over, the standard operating procedure that is being followed is the spikes protocol. And basically what that stands for, it's an acronym which stands for setting up the interview, assessing the patient's perception. What does the patient know? That is the patient's perception. What does the patient know about his or her medical condition? What is the disease? What is the diagnosis? Is it curable? Is it incurable? Is it in advanced stage? What is the prognosis? So what is the diagnosis? What is the prognosis? What does the patient understand? Obtaining the patient's invitation. That is what I was talking about. Does the patient want to know, or doesn't the patient want, or does the patient do not want to know? So if the patient wants to know, the patient will invite for this conversation. And once you have obtained that invitation, then you can share the information truthfully. That is knowledge, sharing of knowledge. And then be prepared for emotions, because after all, it is not a good news you're giving a bad news. You will have to face emotions, and you have to wait till the emotions are drained out, and then you can decide on the strategy, what can be done, what cannot be done, how it can be done, where it can be done, etc., etc. And then you kind of summarize the thing before you close the interview. Remember history taking 2.0, which we discussed last time? So it is kind of just incorporated into the history taking as well. So we have a case, the medical story goes something like this. Mr. Bharat is a 60-year-old gentleman, had been experiencing abdominal discomfort and weight loss for about 2 months of duration. He went to his local doctor, and from there he was given some medications for about a week. There was no relief, and uh, after some investigation, he was referred to the gastro in the city hospital, where a CT abdomen showed a mass lesion, and then OGD biopsy showed a histopathology of carcinoma stomach. An exploratory lab was done, which showed multiple peritoneal metastases. Therefore, nothing could be done. It was just closed. Abdomen was closed. And then the patient was referred to your center for symptomatic and supportive care. Now the patient is sitting in front of you. So now what do we do? So let us hear. So this information you get from the reference letter. So let us hear what the patient has to say. The patient says, I've been having gas since about 2 months time. So I went to my local doctor. He gave me some gas tablets. There was no relief. I took it for 1 week. So I again went back to him. And then this time he asked me to get X-ray of my stomach. So, after that X-ray, he gave me a letter to go to see the gastro doctor in the city hospital. The gastro doctor did a scan and a tube test, and then they told me that surgery was needed. But that time I did not have money, so I went back to my village, and I managed to get some money. Then they gave me a date for surgery, and then I got the surgery done. And after the surgery was done, I got better, and then this they gave me a letter to come and see you. So this is a story that the patient tells you. Now we have to find out the patient's insight, and this cannot be a third interview. But remember history taking 2.0, which we discussed last time. So we have to dig for more information. We have to allow the patient to talk more so that the patient gives us more information. And how do you go about it? So let us, you know, try to do this history taking in a little different way. So the patient says, so I asked the patient, so tell me about your problem from the very beginning. The patient said, I've had gas since about 2 months. So I went to my doctor. He gave me some gas tablets, but there was no relief. So after about 1 week, I again went back to him. So this time he asked me to get an X-ray of the stomach, and then he gave me a letter to see gastro doctor. Wait. Uh, he took an X-ray of the stomach, and what was there in the X-ray? What did your doctor tell you? Uh, I don't know the result. The doctor said that he's giving me a letter to go to the gastro doctor in the city hospital. Okay, fine. Did your doctor tell you why he was referring you to the gastro doctor? What was the problem? I don't know what was the problem. I think for better treatment. Okay. Then what happened? Oh, I went there and the gastro doctor did a scan. And what was the result of the scan? Well, they said something in English I did not understand. Okay, then. So then what happened? Then they did a tube test. Okay, then what was the result of the tube test? That also I don't know. They were saying something, but I am a poor. I mean, I am not that much studied, so I I don't understand what they were saying. Okay, fine. Then what happened? They told me that get surgery done. Did they tell you why the surgery was required? No, they said there was a problem, so surgery is required. Okay, then what happened? I did not have any money at that time, so I went back to the village. My and Then I talked to a few people. I tried to get some money. Finally, I managed to get money enough for the surgery. Then I contacted them. They gave me a date for surgery, and for that I had to go get admitted. And once I had got admitted, I paid all the money. The operation was done, and thereafter they gave me a letter. Uh, what did your doctor say about the surgery? What was the problem? I don't know, but after surgery, my gas problem was gone, but I don't feel very good. I'm always tired. Every day I'm tired. Okay. So then you were saying that you were given a letter. Uh, Letter for what? This letter was to come and see you, to come here. Did they tell you why the letter was given? No, no, I guess they said that the rest of the treatment will be here. I think for better treatment. So when you ask more questions, when you dig for more information, then you understand what does the patient understand? What is the insight of the patient? And this you will get only if you dig for more information. And once you do this, you will realize that the patient has some right information, some wrong information, but a lot of no information, a lot of blank spots. And this is very important for us to know, because when we proceed, we will know what the patient knows and what the patient does not know. So to proceed with the procedure, we have to do some pre-procedure preparation. Update yourself on this, allocate a dedicated time. Some people, some doctors I know, they prefer to talk about this in the morning when they are fresh, when the patient is fresh. In my case, I prefer to do it in the evening because most of my everyday workload is done. I'm a little bit more relaxed, relaxed in the sense, relaxed for time. And I want not to hurry when talking about bad news. So personally, I prefer to do this in the evening. And in my room, there will always be some tissue paper because most of the time there will be some crying, some paper cups, and some water to drink. So to keep things just like in theater, in OT, you have everything handy for a surgery. For a surgery, similarly, this is like a surgery, it is like an intervention. There's an indication to communicate bad news, there's a standard operating procedure, and then there's an expected outcome. And as always, practice active listening skills. So, first thing, sometimes the patient themselves ask, "What is my problem, doctor? Tell me what is my problem." Many patients do not ask. So we may have to explore if the patient is interested. Mr. Bharat, you told me you continue to feel tired. Do you wonder why? Do you want to know more about your disease? Yes, I do want to know more about my disease. So you here is a patient who is interested. But that doesn't mean you go and start telling the patient the bad news straight away just because the patient is interested. For that, you have to first give a warning shot. Mr. Bharat, if it is something serious, would you still want to know? So here is the important part. I am deconstructing. If it is something serious, that is part one. Part two is, would you still want to know?
Hello, sir. Hello, sir. Sir, can you hear me? Mr. Jomi, can you hear me?
That PPT disappeared. I have to reshare. Hello?
Yes, sir. We can hear you. Hear you.
The PowerPoint disappeared. I have to reshare it.
Yes, sir,
Reshare.
you have to. I think your internet went down. That is why the share went off. So can you reshare it again?
Sure, sure. Yeah, right.
Yes,
Can
sir.
you
We
hear
can.
me?
Yes, sir. We can hear you.
So, uh, we were talking about just because somebody says, I want to know, you do not straight away start telling the bad news. You confirm whether the person really wants to know if it is something serious. In Hindi, I would say, अगर बात कुछ serious है, तो क्या फिर भी आप जानना चाहेंगे? In Malayalam, I would say, കാര്യം serious ആണെങ്കിലും അറിയണമെന്നുണ്ടോ? So basically, you have to practice the actual how you are going to say this because that is important. The precision of the warning shot is very important. You can't mess up. This is a very, very important point in the whole interview where we are doing communicating bad news because this is the point where it turns from a normal interview to a serious interview. This is the point from from where it starts. Therefore, you cannot mess this up. So before you actually talk about this to any patient, you have to practice how you will say this. And once you have given a warning shot, if your response of your patient is like this, no eye contact, that means the patient does not want to know. The patient is not mentally prepared to know. Here is a patient who does not want to know. The patient may give some excuses like, give me my medicines, I'll come back after 2 weeks. Or the patient may divert it to tell it to my children, I don't want to. Or the patient may tell you straight on your face, I don't want to. Often the patient may not say anything, but just will not make eye contact. Do not proceed. Do not proceed. Whereas if you see a patient like this, looks you in the eyes and says, yes, I do want to. No confusion. No confusion. Here is a patient who wants to know. So that is the importance of warning shot, because this differentiate between a person who wants to know and a person who does not want to know. Never forget to give a warning shot. Now, as I said, as you become more and more experienced in communication, these things will come naturally. And this is the first part of individualized disclosure model. You have to find out whether the person sitting in front of you wants to know or does not want to. And the next thing is, now here is the gentleman who wants to know. He's saying, yes, I do want to know. Now we have to figure out how much does this person wants to know. And for that, we know what is the person's insight. Mr. Bharat told us a few things. We asked, he does not know what is there in the X-ray. He does not know what is the report of the scan. He does not know what is the report of the what's the report of the biopsy. He does not know why he has been sent here. He does not know what happened in the surgery. So we know that the patient does not know. We know exactly what are the areas that the patient does not know. So once Mr. Bharat looks into your eyes and says, yes, I do want to know, then we tell Mr. Bharat a story. We tell Mr. Bharat his story to Mr. Bharat from the beginning. And while we are telling the story, we fill in the blank. We give him chunks of information that he did not have. Not the entire information. We tell the story, while telling the story, we fill in the blanks. And as we are filling in the blanks, we gradually escalate the information. And all through this, you watch Mr. Bharat's body language. Because as I always say, body language is the major part of any communication. Watch Mr. Bharat's body language, especially the most important, eye contact. If Mr. Bharat stops making eye contact, then pause the story, because it is possible Mr. Bharat has got new information and needs some time to digest this new information. And then the patient, Mr. Bharat, will look back at you and maybe ask a question. Okay, then what happened? Then you can proceed with the story, because that is very clear that Mr. Bharat wants more information. If the eye contact is lost and a lot of time you don't know, you are getting uncomfortable, then you can break this silence by asking a question. And then if the patient continues not to look at you, that means the patient had enough. You stop the story there. That is how you find out how much the person wants to know. Or if the patient continues to engage with you, continues to make eye contact, continues to ask questions till all the information has been shared, that means that's a patient who wanted to know till the end. So wherever the patient wants to stop, you stop. And that is how you tell the story of the patient to the patient from the beginning while filling in the blanks and escalating the information. Mr. Bharat, you have been suffering from gas since 2 months. So here we are proceeding making after giving the warning shot, and Mr. Bharat looks us into the eyes and says, yes, I want to know. Then we start telling the story. Mr. Bharat, you have been suffering from gas since about 2 months. You said you went to your local doctor and he gave you some gas medicines, and you took it for about 1 week, I think, and there was no relief. So you went back to your local doctor, and he asked you to get an X-ray done. The X-ray showed something like a shadow. And to know more about this shadow, he referred you to the city hospital. So you see over here, something like a shadow. You are filling in the blank with new information that the patient did not have. The X-ray showed something like a shadow. And in the next sentence, the information has been escalated. It is no longer something like a shadow. It is shadow. So something like a shadow becomes shadow. X-ray showed something like a shadow, and to know more about this shadow, he referred you to the city hospital. Oh, I didn't know that. See, eye contact there. That means the patient wants to know more. In the city hospital, a scan showed something like a tumor. And to know what this tumor was, they did the tube test called endoscope. So something like a shadow becomes shadow. Shadow becomes something like a tumor, and something like a tumor becomes tumor. So you fill in the blanks and you gradually escalate information. Now there is eye contact. The patient not saying anything, so we proceed. The tube test was done to see if your tumor was something like a cancer. Do you mean to say that I have cancer? I'm sorry, yes. Mr. Bharat, do you want to know more? They had operated and removed my cancer, didn't they, doctor? Uh, I'm sorry. When they opened up your tummy, they found the cancer had spread all over. They could not remove it. They lied to me. Now you see the emotions are coming out. Sometimes it may be in the form of tears. Sometimes it can be in the form of anger. They lied to me. Whatever it is, when somebody is emotional, don't say something, don't do something, just be with the patient. When there is somebody who is ventilating emotion, allow the emotion to flow. Allow the emotion to flow and finish. It doesn't take long, just a minute or two at the most. but don't interrupt somebody who is ventilating emotion. At best, you can place a hand on that person for a moment and then take it off. Don't keep your hand there and forget it. Don't say, don't cry, don't worry, everything will be all right. Don't say anything like that because those words are of no value when you have just told something terrible to the patient. It is their right to express emotion. Don't say something, don't do anything, just be with the patient. Allowing ventilation of emotion is therapy. Allowing ventilation of emotion is therapy. Once you have somebody in uh, emotion, and people may say something in emotion, I'm so scared, I'm so worried, and how much time do I have? Please remember, you have to ask. Do not assume why they said what they said, because people can have different reasons for saying the same thing. So here is this Mr. Bharat who's saying, how much time do I have, doctor? Do not assume, ask. Why do you ask that? Why do you say that, Mr. Bharat? My daughter's marriage is fixed after 6 months. Should I arrange it earlier? So here is the patient, here is Mr. Bharat who wants to know how much time he has because he has things to do, he has plans. I'll give you another scenario. Here is another patient, another Mr. Bharat, saying the same thing. How much time do I have, doctor? And I ask the same thing. Why do you ask that, Mr. Bharat? And this another Mr. Bharat said, why did God do this to me? So here is a patient who needs to ventilate more. Not he, this another Bharat does not want to plan anything. This another patient asked the same question, but for a different reason. That is why it is very important never to assume, because to assume is to make an ass of you and me. ASSUME. Never assume, always ask. And then you will know. They will tell you, just have to ask. And how you deal with a person who wants to plan something versus how you deal with a person who needs more ventilation will be totally different. And once these emotions are sorted out, then you can sit and talk about what to do, when to do, how to go about it, where to do, what is possible, what is not possible, and honest, clear, and precise exchange of information. This comes in the end. First, you have to allow the ventilation of emotion, because if somebody is high in emotion, they just cannot have a rational discussion. Your brain does not work. Your brain will start working only once the emotion has been drained. For that, you have to give time, and you do not interrupt. When you interrupt, the emotion gets interrupted, it doesn't drain away. Therefore, it is important to be with the patient, allow ventilation of emotion. Don't say anything stupid, don't do anything stupid, just be there. The patient will calm down, then you can have the discussion. Once you have discussed, always end up with hope, but give realistic hope, give achievable hope, never give false hope. Sometimes you may have to fast track communication, especially you may not be able to communicate with the patient because the patient may be unconscious or gasping. It just happens sometimes in ICU or ER, casualty, and you have to communicate with the family. Sometimes you do not have time to understand the insight and things like that. So fast tracking, first and foremost, make sure you have the correct identification. Telling a bad news of a patient to somebody else is a very, very serious trouble that you can get into. So, are you the son of Mr. Bharat, hospital number so and so, who was admitted yesterday evening? Yes, doctor. How is he now? Despite all the efforts, he is deteriorating. I'm afraid he's not going to make it. Short, simple, and clear. Not no beating around the bush. If you don't have time for niceties, don't do it. Make it short, simple, and clear. But he was not this when he was admitted. He all literally walked in. Uh, yeah, he has been rapidly going down. The virus is really hard on. I'm sorry, despite all the efforts you have put in, he is still sinking. So empathy, how you say it matters. And you see, I have put you in red. Many a times we end up saying we have done everything possible. They are not interested in what we have done. They are at a personal level, maybe feeling guilty. Did we bring to the right place? They're guilty. They may be feeling guilty. Did we bring on the right time? They may be feeling very unsure about what will people say, what will others in the family say, what will relatives say, whether we did not make enough effort. This is the psychology of every person. Every person is self-centric. And when you assure them that you did your best, you have done the best possible, despite that, you will see immediately they calm down a little bit. That is one way of managing anger also. Telling them that you have done everything possible for this. Most of the time, we medical people say we did everything possible. So we did everything possible, implying that, you know, now you deal with it. So when we tell them that you did everything possible, you did the maximum for your loved one, you made so much effort for your loved one, despite that, the person cannot be saved. They feel much more comforted. They feel validated that some professional, some doctor, some nurse, somebody told them that they did the right things. So that is the difference in communication, the right kind of communication can make. Plus, it does not make us defensive. We are not putting the onus on ourselves. We did everything. What if we had gone to a better hospital? What if we had gone to some place with more facilities? So that kind of situation we are preempting by saying that you have done everything possible. You have taken to the best possible place. You have taken so much effort. You have spent so much money, energy, time for this, despite all your efforts. So we put the onus on them, that in a sense that they have done everything for the patient despite that research. So how you use the words, how you turn the phrases, that is very important. What should we do now? Inform everybody in the family, and as soon as the end happens, I will inform. So you're instructing them, giving them clarity, and you're also being helpful, that as soon as the end happens, I will inform you. And then another thing that you can do is, if it is
Hello, sir. Hello. I think there is some internet connection with Biju Raghavan, sir. He will be getting back soon.
okay, I would on behalf of all of us. Majority of the people believe. Hello, can you hear me?
Yes, sir. We lost you for a minute.
Yeah, I keep getting calls from the hospital in between.
Okay, sir.
Unfortunately, yeah, right. Okay, then.
Yes, sir. You can continue.
Right. So now the last part is how to manage anger in the clinic. Remember, we are not talking about law and order situation here. If there is a mob violence, there's a large crowd getting violent. We are medical professionals. We do not know how to manage a large crowd. That is the police who is trained for managing that kind of situation. We are medical people. So if we are facing a mob violence, run away from that. That is the only thing I can tell. If you're dealing with people who are under the influence of alcohol or other intoxicants and getting violent, you cannot deal with them. That's a law and order problem. Managing anger in the clinic environment. That hello,
Yes, sir.
yeah. So anger, uh, how you define anger? It is a emotion. It is a negative emotion, and it is a high energy consuming negative emotion. So basically, if you cut off the energy supply, you can manage anger. Question is, where is this energy coming in for anger? Do we ever get up in the morning and decide today I'm going to be angry with somebody? I have not been angry for the last 1 month. Today I'm going to get angry. Nobody gets up in the morning and decides that. It is a lot of stress that builds up, which leads to anger. And remember, in our healthcare uh, practice, service, we are dealing with patients and their families who are dealing with sickness, sometimes serious illness, a lot of suffering, physical suffering in the form of pain, breathlessness, a lot of mental suffering in the form of anxiety, fear, sadness, depression, anger. We are already dealing with people with a lot of negative emotion. And a lot of stress builds up just by sitting and waiting because most of our hospitals are so crowded that it takes a lot of time for people to access healthcare. The if even if the patients are admitted, the number of nurses are very limited. So when somebody has a problem, for the nurses to reach and provide care and give medication, these may get delayed. So a lot of reasons happen, and even in resource-rich countries where you have better patient-staff ratio, even there, just because we are dealing with people who are sick and suffering, and family members who are dealing with the suffering of their loved one, it is very, very common to experience anger. So, first and foremost, nobody likes to get angry. It is just the fact that a lot of negative energy builds up, a lot of stress builds up. As a result, the anger happens. And when somebody is angry, there are two ways of increasing the anger. There are two ways of increasing the anger. One is to become confrontational, arguing, telling them that they are wrong, or making excuses. And sometimes, if somebody is very, very angry, even apologizing to them can make them more angry. That depends on the intensity of anger. But by and large, any kind of confrontation, there are many, many ways of confronting the patient, trying to explain something to somebody who's very, very angry can become confrontational. So, any kind of confrontation can increase anger. The second source of how we can increase anger is by ignoring the angry person. If the angry person feels that you are purposefully ignoring, for example, your body language, if you are turned away from that person, if you are not making eye contact, if you are behaving as if you are not listening, you are busy, all of these things can also make the person more angry. So, any kind of confrontation or any kind of ignoring the angry person can increase the anger. So, how do we go about it? Here is somebody who is very angry in your near your at your workstation, very loud voice, using bad language. Look at the expression on the face, very, very fierce. And you will realize that those who are very angry, there is so much of adrenaline. They can't sit down comfortably. They have to either stand or walk around because there is so much of adrenaline. Their body just cannot be calm. And what you have to do is just be the opposite. You have to behave in a very calm manner. Now, how do you do that? As I said, body language is almost everything, especially in dealing with anger. Many a times we see that when somebody is getting angry in the hospital, you will see that the doctor or the nurse is usually sitting. This itself will increase anger because when somebody is standing and another person is sitting, this creates hierarchy and this will increase anger. Because if you, as a nurse, if you are sitting in your nursing station and somebody is angry and shouting at you, or as a doctor, if you're sitting behind your table and somebody is getting angry with you, just get up. Because when you stand, your body is telling the angry person's brain that you consider him or her as equal. Standing position shows equality. The same position is important because an angry person cannot sit. Angry person will by force will be standing. You also stand up and equalize the body position. Both bodies are in standing position, creating equality. That is a positive body language. Second, the body posture. When we sit down, if we bend slightly forward, slight kyphosis, we said it creates this impression that I'm here to listen to you. The same thing you can create with your body in standing position with a slight bend forward, a slight kyphosis while you're standing, which again shows respect and you are showing I'm here to listen to you. And keep your hands in front because psychologically our primitive brain, we still carry primitive brain. We know that there can be some uh, weapon in the hand. So one way of calming down people is to show your hand. So keep your hand in front because you with this you are showing I do not intend to harm you. I am not a threat to you. I do not mean to harm. So this is the three things while you are confronting somebody angry, stand up. While you're standing up, be respectful with the posture slightly forward, slightly bent forward, and keep your hands in front of you. Now let us focus on your face. Maintain eye contact. Do not look away from the person. Look at the person because this shows that I am confident. I am not afraid of you. I consider you my equal. I am respectful towards you. I do not mean to harm you. At the same time, I am not scared of you. I am confident, but I am not arrogant. My body is not showing any arrogance, but my eye contact shows I am not scared either. I am confident. Do not smile because smile can be seen as a confrontation. Keep your face serious. This is the only situation where we say that keep your face serious. And of course, if somebody is crying, for that also you have to keep face serious. But any somebody displaying any negative emotion, do not smile because when you keep yourself serious, you are showing that you take the person seriously, and people want to be taken seriously, especially somebody who is getting angry. And what we learned in active listening, encourage the person to talk, encourage the person to ventilate by nodding your head. But this time, don't make sound. Okay, go on. So these kind of sounds don't make, but just nod your head. So we have talked about some six very important body language. Standing position, slightly bent posture, hands in front, eye contact, serious face, nodding your head. So when you are doing this, basically you are allowing the person to ventilate the emotion, and you are fast forwarding because you are neither confronting nor ignoring this person. You are not saying anything to confront, no argument, no excuses, nothing, no explanation, nothing. Just silently you are allowing ventilation. And once you do this, you will see that gradually the anger starts coming down. The volume of the sound comes down, the pitch of the sound comes down, and the tone becomes more civil, and the bad words become reduced and totally go away. And once the severe anger goes away, the person calms down a little bit. The anger still is there, it is not gone completely, but still the major anger has come down. At this point of time, you can give an invitation to sit down and talk. I want to know more about this. Can you sit down and talk somewhere? Do not give an invitation to sit and talk in the beginning, because that again will be taken as a confrontation. At this point of time, where a lot of anger has flown down, has been ventilated, the patient has become calm and now in a position to listen to you. When somebody is in high emotion, they cannot listen to you. The brain will not work. So you ventilate the emotion, and then the person start listening to you. Then you sit and listen. So now instead of standing, you're sitting. Maintain the posture little slightly forward. Keep your hand on the table or where the patient can see, or where the angry person can see. Maintain eye contact. Keep your face serious. Note, keep nodding your head. But this time you can start asking questions. So what happened? Then what did they say? Then where did you go? So this way you allow this person to ventilate more of that emotion which made the person angry. Find out what the story was. And if there is some problem that can be resolved, resolve it to the best possible way. However, if you have a solution, of course, you offer a solution because that's a good way of ending it. If an apology is merited, then do apologize, but never give an insincere apology. Never apologize for the sake of apology. It is not mandatory that when you deal with somebody who is angry, that we are wrong and we have to apologize. Nothing like it. Only if it is absolutely necessary, where it is merited, that yes, this is a situation where an apology is due, then of course give a sincere apology, never give an insincere apology. You can also say something like, thank you for bringing this to our notice. We are very sorry you had to experience this. So you are giving this with an apology, or you can do this without an apology. Thank you for bringing this to our notice. So this is what we're going to do in future so that this doesn't happen to others. So it depends on what the situation is. You can end it very well. So I know we have exceeded the time. I'm sorry for some clinical reasons. I could not start on time today. Still a lot of patient and clinical work is pending. So the last slide, listen to the family, and that is how we manage pollution. The most important management strategy of pollution is to listen to the family. Other things comes later. As far as communicating bad news, telling the truth, remember you are only a facilitator of information. The patient decides whether they want to know or not, and if they want to know, how much they want to know. Ventilation of emotion is a therapy. Remember, it is never a waste of time. You just pause, allow the person to ventilate, whether it is tears or anger. It is an excellent way of treating the emotional distress. Ventilation of emotion is a therapy. It is never a waste of time. And as far as anger is concerned, non-confrontational, active ventilation of anger that we just saw just now, it is an easy skill to master. Among the three communication procedures we discussed today, managing anger, clinical anger is the easiest skill. The next harder part, easy means it is not easy, but if you learn, you practice, it becomes easy. The harder skill is communicating bad news, and the absolutely difficult part is is how to manage pollution. With this, I uh, come to the conclusion of today's session. I will stop sharing. Yeah, there we go.
Thank you, sir.
If
Thank
there
you.
are any questions, I'll be happy to take. I saw a few hands coming up and a few questions that came up in the chat box. I think I'll stay back and ask and answer the questions at least.
Sir, I think we can go to the case presentation, and after that we can get back to the chat box if they have any doubts.
No, I have a problem because hi Babu, good to see you.
Hi, sir.
Thing is, I have a lot of patients that needs to be seen. Some in the ICU, some family members are demanding to see me. OP also. This is the problem with having the session during the active part of the clinical day. 3 to 4:30. So I'll take some questions when I leave, and you can have the case discussion afterwards.
Okay, sir. Participant, if you have any doubts, please feel free to ask.
I think if you go through the chat box, I think there are some questions there.
Sir, actually, there are questions. There are some comments. That's like exactly the time according to the need of PTs, because different from TTs and other like that. Some only some comments.
Right. Please, for the
Questions.
delegates, you have to understand that every situation will be different, whether it is managing pollution or communicating bad news or dealing with anger. I'm just giving you certain signposts, certain guidelines. This is the direction to go. So this is just a guideline, so to speak. So you have now a method, a step-by-step method of dealing with these kind of problems, and then how you use it and how you get better and better the more you practice. It's all up to you, and I wish you the best. If there are
Thank you,
no
sir.
questions, then I will proceed to leave.
Okay, sir. Thank you so much for your valuable time. Looking forward to have many classes with you again. Thank you, sir.
Sure. Okay.
Participants, I think our faculty has left, and today Shiva ma'am is also busy with some other works. And I think we cannot have our case presentation without our faculty or without our facilitator. I'm so sorry. And Miss Iba ma'am, I'm so sorry I didn't feel like this. And I think we can have the script presentation on another day. Okay, then, and I'm going to share you the feedback link with you. I'll be sharing it in the chat box and in your WhatsApp group also. So please feel free to fill it up. And I have to say something that everyone should on their videos when the class is going.